Next speaker is Dr. Stephen Kim, who will be discussing retinal ophthalmic technology assessments that will change your practice.
Great. Thank you, Caroline, and thank you for the invitation to give the results of the committee's findings. So the first question is, what is an ophthalmic technology assessment? So in 1982, an ad hoc committee of ophthalmic procedures assessment was first chaired by David Guyton. So why a committee to assess procedures? Well, the AO anticipated at that time a demand for such assessments about safety, effectiveness, and appropriate uses from the Healthcare Financing Administration, now CMS, insurers, and individuals. The first assessment was actually published in the Blue Journal, Punctal Occlusion for the Dry Eye in 1988, and this was followed by keratophakia and keratomillosis safety and effectiveness in 1992. In time, the word procedure got replaced with technology to recognize the fast-growing imaging technology and to broaden the scope. So today, the goal in ophthalmic technology assessment is to systematically review the best available evidence for clinical efficacy and safety of a technology and/or intervention. These assessments undergo a rigorous process, intensive review process by international and national organizations and experts. Their published assessments are approved by the trustees of the Academy and therefore have the full backing of the Academy and become official statements. All OTA or ophthalmic technology assessments undergo an extensive literature search in PubMed, the Cochrane Library, databases, and other sources. Relevant citations are all graded by a methodologist based on a scale developed by the British Center for Evidence-Based Medicine. Level 1 rating is assigned to well-designed and well-conducted randomized clinical trials. Level 2 rating is assigned to well-designed case control and cohort studies and poorer quality randomized studies. And level 3 is essentially everything else, case series and case reports. So the committee assessed toxoplasma retinitis. This is the leading infectious cause of posterior uveitis. A 2002 survey by Gary Holland demonstrated substantial variation in treatment among uveitis specialists. There are a lot of questions about best treatment regimen, initiation and timing of corticosteroids, and also prevention. So the question for assessment was, what are the outcomes and safety of interventions for toxoplasma retinitis? And three main outcomes were looked at: visual acuity, risk of one or more recurrences, and lesion size. In the assessment and literature review, there are only 3 randomized placebo-controlled studies in the literature. The first one, done by Perkins, dates back to 1956. There's substantial questions about the diagnosis of toxoplasma in many of the patients. They didn't look at visual acuity, recurrent lesions, and had no documentation of lesion size. They also reported a very high rate of adverse effects to pyrimethamine. Acers published a study, a randomized study in 1964. It only had 20 patients. Also similar limitations. No visual acuity was measured, no change in lesion size, and also very high rates of side effects to pyrimethamine. Severa is a more recent study on prophylaxis using Bactrim every 3rd day. They report a favorable effect, but also there are flaws with the study. No measurement of visual acuity or change in lesion size, and this was only given a level 2. So in conclusion, despite widespread and common practice, there's really a lack of level 1 evidence to support routine antibiotic and corticosteroid treatment in immunocompetent patients with toxoplasma retinitis. And keep in mind that antibiotics have costs and they have side effects. There's level 2 evidence that prophylactic treatment can help in some patients, with the caveat that these studies are done in Brazil, and the genotype for Toxoplasma gondii is much more virulent in those countries and may not be directly extractable to North America and Western and Europe. So the committee also looked at NSAIDs and cataract surgery. So why did we do this? Well, CME is a common complication after cataract surgery. We all deal with some of this. But most eyes with CME resolve spontaneously, and mild cystoid changes on OCT may not even be clinically important. That said, the majority of surgeons that we poll use a combination topical NSAID in addition to, but not as a replacement for topical corticosteroids. And the question is this worth it? Does this have value? At a societal cost of almost $700 million a year. So the question for assessment was, does prophylactic routine use of NSAIDs improve long-term visual outcomes after cataract surgery? There are 2 pervasive beliefs in the literature that we sort of had to tackle. One, this concept that corticosteroids and NSAIDs are synergistic. Is this fact or is this fiction? And there's no evidence that they're synergistic. They have overlapping mechanisms of action, so you wouldn't expect them to be synergistic. And probably at best, they have an additive effect. The other pervasive belief is that NSAIDs are more effective than corticosteroids at reducing CME. Is this fact or fiction? There are many publications and published in the Blue Journal that support this. This is a systematic review by Line Kessel that shows we found high-quality evidence that topical NSAIDs are more effective than topical steroids in preventing post-cataract macular edema. The problem is that many of these studies compare NSAIDs to fluoromethanol alcohol, which has minimal penetration into the eye. So are NSAIDs more effective than corticosteroids at preventing CME? only when compared to corticosteroids that have minimal penetration into the eye. So despite widespread and common practice, there is a lack of level 1 evidence that prophylactic use of NSAIDs, when applied solely or in combination with corticosteroids, improves long-term visual acuity outcomes after cataract surgery. We also looked at ARN, acute retinal necrosis, which we had some talks on today. First described in 1971 by Urayama and colleagues, acute panuveitis and periarteritis and diffuse necrotizing retinitis. A number of changes have occurred over the last several years, and a number of questions have arisen. What is the role of PCR? Does this become standard of care? Do we have to admit every patient for intravenous therapy? Does adjuvant intravitreal therapy offer benefits over just systemic therapy alone? And what's the role of prophylactic laser retinopexy and vitrectomy? So PCR testing is useful and highly recommended. In the right setting, it has very good positive predictive and negative predictive value. We don't have to admit patients anymore as long as there's no CNS involvement and as long as we use induction dosing of 6,000 milligrams of valcyclovir. Adjunctive use of intravitreal foscarnet is valuable, but the evidence for this is less robust, and there's no evidence that prophylactic laser retinopexy or vitrectomy actually reduces the rate of retinal detachment. So Justice Ehlers first authored an assessment on macular edema associated with BRVO. The question is, what is the current safety and efficacy of available therapeutic options for the management of BRVO? Not surprisingly, there's robust level 1 data that shows anti-VEGF therapy results in significant visual acuity improvement, but there's very little data on differential effectiveness of anti-VEGF agents, switching between agents, and optical long-term dosing schedule. There's also level 1 evidence that supports intravitreal corticosteroids, but the side effect profile is greater, and all the other technologies and interventions had less robust data. Sophie Bakri first authored an assessment on anti-VEGF pharmacotherapy for AMD, which is the leading cause of central visual impairment. The question for assessment was, are the various anti-VEGF therapies safe and effective for the treatment of neovascular AMD? And we know that intravitreal anti-VEGF pharmacotherapy is safe and effective for up to 2 years. The best available evidence indicates that continued follow-up and treatment after 2 years is necessary, and that earlier delivery of anti-VEGF therapy has long-term benefits in terms of visual acuity. And finally, Steve A. first authored an assessment on macular edema from CRVO. Over the years, many different interventions have been looked at, including radio-optic neurotomy and chorioretinal anastomosis. And the question was, how safe and effective are currently available interventions for macular edema with CRVO? And to quickly summarize, intravitreal anti-VEGF pharmacotherapy is safe and effective for 2 years. Delay in treatment is associated with worse visual outcomes in long-term wise. Corticosteroids demonstrate short-term efficacy, but high-frequency adverse events, and the remaining technologies have less robust evidence. So I want to thank you for your attention and the opportunity to speak.